Hi, so I hope you've enjoyed this small pupil cataract surgery series. I hope you've learned something from it, and I just want to review a few guiding principles uh, whenever you see and evaluate these patients. Number one, when you see a patient in clinic whose pupil does not dilate well, you have to think, why is the pupil small? Why did this patient not dilate well? Does this patient have a history of perhaps a laser iridotomy or something else which has caused posterior synechiae? Is the iris fused to the anterior lens capsule? Or does this patient have pseudoexfoliation? Do I need to worry about zonular laxity? Do I need to worry about other issues? And perhaps a small pupil is just the tip of the iceberg. So that's principle number one, is think about, why does this patient have a small pupil? Principle number two is have a plan for how you're going to address this during surgery. Have a plan for how you're going to address this if the pupil dilates even less or comes down during surgery. How are you going to manage that? Be comfortable placing iris hooks. All right, so those are some of the guiding principles. Let's talk about some of the lessons that I hope that you've learned from watching these cases. Number one, I want to leave you with the feeling that small pupil cataract surgery does not have to be a stressful experience. A cataract can be removed safely in a patient who has a small pupil. It's important to have a plan. Number two, the other principle is stabilize the globe while you're doing the capsulorrhexis. I like to use 0.12 forceps at the paracentesis. There are many other ways to stabilize the globe while you do the capsulorrhexis. You don't want to be worried about the patient moving while you're doing that. Number three, when you're doing the capsulorrhexis, it's okay to be right up at the pupillary margin. If the pupil is smaller, you can even go underneath the pupillary margin. Of course, you don't want to do this in your first few cases. You want to be comfortable doing a continuous curvilinear capsulorrhexis first and get used to making that motion, having your hands have the muscle memory of how things go with a capsulorrhexis. Number four, whenever you're hydrodissecting, watch for iris prolapse. If you do see the iris starting to prolapse, you want to decompress the anterior chamber. You want to, first of all, stop injecting BSS into the anterior chamber. Number two, you want to decompress the anterior chamber. You do that by pushing on the posterior lip of your wound. That lets viscoelastic and aqueous and fluid out of the anterior chamber and allows the pressure inside the anterior chamber to be lower, thus allowing the iris to fall back into the eye. Only after you decompress the anterior chamber can you consider doing something like putting a little bit of dispersive viscoelastic at the wound to push the iris back in. If you don't decompress the anterior chamber first, you will not be able to replace the iris without considerable damage to the iris. Number five, you can use a second instrument to retract the iris. I use the Charvel. There's certainly other instruments you can use to move the iris out of the way so you can see if there's any remaining cortical material that you may have missed or any remaining nuclear fragments. And then finally, number six is you want to make sure that the intraocular lens is inside. And then finally, number six, you want to make sure that the intraocular lens is inside the capsular bag. The last thing you want to do is do a perfect cataract surgery, and then for whatever reason, because of poor visualization, you leave one of the haptics inside the sulcus space. Unlikely, but it has happened. So whenever you put the IOL in, make sure that you can retract the iris and take a look or depress on the IOL centrally and make sure you're completely inside the capsular bag. So I hope you've enjoyed this case series. I'm going to attach or append all the cases here to the end of this video. So if you have not seen them individually, you can just watch this video and see all the cases together. Please leave, as always, please leave any questions or comments or share how you like to manage small pupil cataract cases. Thank you very much. Enjoy. We'll see you soon. Small pupil cataract surgery. Cataract surgery in the eye that does not dilate well. This is a case I found from 2016, almost 10 years ago now. You can see the pupil is quite small. Here we're injecting viscode viscoelastic to fill the anterior chamber. We can see there are posterior synechiae from about 5 o'clock to about 12 o'clock. So covering at least 6 to 7 clock hours. This is a keratome making the main incision. This is from 10 years ago, so the video quality is not quite as good. But I think we can illustrate the main points here. It looks like here I'm enlarging the incision a little bit more than that. Looks like a 2.2 blade. So posterior synechiae, how do we approach this? The first thing I probably will end up doing is going in with a cyclodialysis spatula to free up the posterior synechiae, free up the iris from the underlying lens, from the underlying cataract. You can use actually very many different instruments you can use to do this, but I found the cyclodialysis spatula works really quite well and is quite adequate for this part of the procedure. So we freed up the posterior synechiae. So now we have several options here for how to proceed. You can see the pupil is quite small, maybe about 4 millimeters. Looks like I'm going in here with viscoelastic to see if I can dilate it any more. And so you can do viscodilation or viscomydriasis, see if you can get the pupil any bigger, and that actually enlarges probably enough to do capsulorrhexis. Of course, at this point in time, you also have the option of placing a Malugin ring or similar pupillary expansion device or using iris hooks. It's important to use technique that you're comfortable with. It's important before attempting to do these kind of surgeries without a pupillary expansion device that you're comfortable placing iris hooks or rings, so that if you do get into trouble, you can always stop the case and place an iris hook at that point in time. So there's a little bit of a delay here. It looks like I'm contemplating and considering different options. As I said, this case is from 10 years ago, but it looks like I'm ultimately going to go in here with the cystotome and start the capsulorrhexis. So this is where before I started creating a flap with one continuous motion, you can see I move to the side and then I make a few extra motions there to lift over the flap. And then I'm going in here with my capsulorrhexis forceps. These forceps were actually quite nice. They weren't cross-action forceps, but they did have markings every millimeter or so, so you could tell exactly how big your capsulorrhexis was going to be. And you can see here that I'm making the capsulorrhexis right at the pupillary edge, and even I'm not too scared to go underneath the pupillary margin. I think you'll find, and there I'm sizing the capsulorrhexis there, and it looks like it's about 5 millimeters. I didn't actually catch that. But I found that when you go underneath the iris margin, it's pretty rare that the capsulotomy will run out. I'm doing a hide dissection here. It looks like I am tenting up the capsule. This is before I had observed that you could do this, had the sign called the triangle sign, where you can lift up the capsule and see where the capsule is mechanically separated from the lens, which you really can't do in a small pupil anyway. So at this point in time in my career, I think I was doing hydrodissection and hydrodelineation both. Hydrodissection, of course, is separating the cortex from the nucleus, and then hydrodelineation is separating the epinucleus from the nucleus. So going in here with phaco, this is a Venturi system, which is what I used back then, the Bosch & Lomb Stellaris. And I would go in and I would make just a central core where I could put my phaco probe in, and then I use the same chopper, the Nagahara chopper, to do a horizontal chop maneuver. So let's see how that plays out here in this eye with a small pupil. I'm going underneath there. Of course, you can't see what you're doing here, but the anatomy, that's a nice crack. But you know the anatomy, and if you're staying close to the nucleus, you're going to push the capsulorrhexis opening aside, and you're going to go around the equator and chop that nucleus. And we've got a quarter of the nucleus here chopped, and it looks like I'm going to go ahead and take that now. Obviously small pupil, so we want to avoid getting the pupillary margin in the phaco probe. And we're making some progress here. It looks like we got most of that quarter out. Rotating the nucleus. And we're probably going to do some more horizontal chop here. But so for these small pupil cases, there's many different ways to do it, and do the technique which you feel most comfortable doing. But the combination of the hydrodissection, the phaco chop maneuver, makes these cases really quite amenable to removal without when the pupil actually is really small and the view is limited. If at any point in time you run into an issue or a complication, then you put in iris hooks here, and then you can address whatever issue is going on. You can get better visualization to see and manage any potential complication that may be coming up. So we're working through here, removing the nucleus. And as I said, we are making good progress. I'm already using my second instrument here for this last piece. We have an epinuclear shell here, and that with the Venturi system, that just really comes out very nicely. That may be actually just the last piece of nucleus there, but let's see here how we do. There's still an epinuclear shell there, and we'll see if we get that with the phaco probe or not. And it looks like we are. Okay, and then we still have some cortical material here, and so we'll go with IA to remove that cortical material. But you can see how with the Venturi system, it becomes, you can readily get that epinuclear shell. I think it's harder to do that with a peristaltic pump system. And in fact, since I've moved to a peristaltic pump system to the Alcon Centurion, I no longer how to delineate, and I no longer leave an epinuclear shell. So it is important when you watch these videos that other surgeons post that you think about what machine they're using and whether you can apply their techniques to your setup that you have in your operating room. And of course, always feel free to reach out. I think for most people who post videos, they enjoy hearing questions and are happy to answer questions about their technique and what machines they use and settings, etc. So here I'm using the Charvel to retract the iris and try and get that cortical material. It looks like this cortical material is pretty sticky. I did not achieve a cortical cleaving height dissection here. But we are making progress, and we're able to get that cortical material. This Charvel is a really nice instrument for retracting the iris. Of course, whenever you manipulate the iris a lot, it can increase postoperative inflammation, and you may need to use steroids more frequently than you normally would if there's a lot of iris manipulation. Looks like I'm using a Lester here to pull the iris in. So, one criticism is if we had used a ring here or iris hooks, this part we wouldn't have had to retract the iris so much to piecemeal out this cortical material. The counter argument, of course, is it takes a little bit of time to put in iris hooks, and you have to make 4 extra incisions. But nonetheless, I think both approaches are valid. Now, when I do a cortical cleaving height dissection, and I'm able to separate out the cortex from the capsular bag, I rarely have this issue where I have to spend so much time doing IA and retracting the iris. And I think that's part of the reason why I've shifted away from using pupillary expansion devices for most of my cases with small pupil. So what we have left here is some subincisional cortex, which we're able to get here with the IA. My field of view in the microscope, of course, when operating is larger than what we're seeing here in this video, so sometimes we'll go off frame here. Well, it looks like we're doing a pretty good job staying centered. All right, so essentially this cataract is out. We have some material there, it looks like on the posterior capsule. And so I may end up doing some polishing. It looks like I'm just retracting the iris, taking a look, making sure I'm not having left anything behind. I'll probably want to polish that posterior capsule. So if it was me doing this case today, I'd use a Terry squeegee. I may have been using it back then as well. We'll see here. Looks like I am. So this is a Terry squeegee. It's got a silicone tip. It's a cannula with a silicone tip, and you can use that to touch and irrigate directly on the posterior capsule, which is what I'm doing here. And I will do that to remove any material that's remaining on the posterior capsule. But if there's something that's really adherent, I'm not too aggressive in trying to remove it. I'd rather save that later and do a laser capsulotomy. In any case, at this point in time, we've removed the cataract, we've done irrigation aspiration, removed the cortical material, we've polished the posterior capsule. We're going to inject viscoelastic here to fill the capsular bag. It is possible still to get iris prolapse at this stage of the procedure, so it's important not to overfill here. And then I would expect now that we're going to be putting in the intraocular lens. Okay, so I'm using a contour wand to stabilize the globe through the paracentesis. I'm using a one-handed technique here in terms of injecting the lens. So this is a push injector, and this must be a Softec lens, which is a hydrophilic acrylic lens, which is the lens that I was using during that time period. Placing the IOL here into the capsular bag. I no longer really do this step. I just go straight in with the irrigation aspiration probe. And I'm verifying that the IOL is in fact inside the capsular bag. That capsulotomy looks really small. I would say it's probably in the order of actually 4 millimeters or, 4 millimeters or less. Probably 4 millimeters here. So then we go in with IA, and we are going to be removing the viscoelastic and any remaining cortical material that wants to come forward. So it looks like here I'm starting behind the IOL and removing viscoelastic from behind the IOL. And then we'll remove viscoelastic from the anterior chamber. I'm going to speed this up here. So this is now 2x speed. And once again, it looks like I'm going in with the Charvel, and I'm looking for any remaining cortical material. So I showed this case because, number one, it is from 2016. And I realized I've been doing this technique where I don't use pupillary expansion devices now for quite some time. And then also, I think as you gain experience over the years, you don't spend as much time double checking things like we see that I'm doing here. So I have double checked, made sure there's no cortical material remaining. I irrigate the wound and I irrigate the paracentesis. And we'll check the wounds and make sure they're watertight. So I know we're all surgeons and we have different preferences for our techniques. And the goal here is that we learn from each other. If you're in training, it's important to see different techniques and really see what you like and work towards the techniques that you like. Over the next few weeks, I'm going to be posting small pupil cataract surgery cases. And I look forward to hearing your feedback. And if you have requests for certain videos you'd like to see, please comment in the comment section below. Thank you for your attention. Have a great day. Hi, Muhammad Al-Mala here with another case of a patient with cataract surgery in a small pupil. As you can see here, the pupil actually is not that small. It's probably about 5 millimeters or so. But when I'm seeing a patient in clinic, if they do not completely dilate, I always make a note to myself of how much the pupil actually dilated. And I like to have a plan before I get to the operating room of how I plan to manage when the pupil does not dilate all the way. In a case like this where the pupil dilates about 5 millimeters, I do not use any pupillary expansion devices. But the final decision is made when I have placed the viscoelastic into the anterior chamber and we've achieved viscodilation or viscomydriasis. At that point in time, I'll make a decision as to the size of the pupil and whether or not I want to use a pupillary expansion device or iris hooks. So as we can see here, the case is progressing nicely. We're doing the continuous curvilinear capsulorrhexis. I'm using my 0.12 forceps to grab the paracentesis and get rock solid stabilization of the globe. The patient may try to move right and left, but with the 0.12 forceps there, you're not going to get any movement. Here I'm decompressing the posterior lip of the wound. Why am I doing that? In order to try and prevent iris prolapse. Whenever you have a small pupil, it doesn't dilate well, the iris is going to prolapse when you do hide dissection. So as soon as you see that happening, you want to stop injecting fluid into the eye, stop increasing the pressure inside the eye, push on the posterior lip of the wound, decompress the anterior chamber. That allows the iris to fall back into the eye. So we are now going to do phacoemulsification. We're going to phacoemulsify this nucleus. We're going to bury the phaco tip into the nucleus. We're going to do a horizontal chop technique with the Nagahara chopper. And we're going to split this cataract into two heminuclei. Nucleus disassembly, you've seen it. You've seen my phaco chop technique in my other surgeries. But basically, once we get the two heminuclei, we're going to split it into quadrants. And I'll either start taking the pieces now, or I'll rotate and take them all together. So it looks like here we're rotating. And we're going to chop that second heminucleus into 2/4. And once we've got that nice into 4/4, we can go ahead and start removing these nuclear pieces. I use the same mode throughout. I use my quadrant removal mode setting when I'm impaling the nucleus and chopping it, as well as when I'm eating up these pieces here. So we can see that we've already removed 2 pieces of the nucleus, and we're removing the last quarter here, the 3rd quarter, and now the last quarter. This piece is rather large. It all wants to come together, but it's relatively soft, so the phaco should handle this nicely. This is the Alcon Centurion machine, and we are removing the last piece of the nucleus here. It looks like there are some cortical fragments remaining, or I'm sorry, not cortical fragments. There are some pieces of cortex still attached to the capsular bag, and so we're going to use irrigation aspiration here to remove those. As I'm waiting for my tech to get my IA probe ready for me, I use BSS and a 30-gauge cannula through the paracentesis just to remove any material that may be hiding in the paracentesis. Irrigation aspiration here to remove that cortical material, peel it off the posterior capsule. We did not see a triangle sign here. We did not achieve cortical cleaving height of dissection. And you know what? That's okay. We don't have to get it 100% of the time. We'll use IA to remove the cortical material, and that comes out rather nicely. Once we get that out, I'll often use a Terry squeegee, a cannula with a silicone sleeve, to irrigate and remove any lens epithelial cells that may be stuck to the posterior capsule. Really not a whole lot there. Provisc, we put that to the right and left of the wound. We want to remove any material that may be hiding in the anterior chamber angle. We don't want to have to come back to remove nuclear chips. We fill the posterior capsular bag. We fill the capsular bag with viscoelastic. We put in the IOL, and we're going to go straight in with the IA probe to place and center this lens, get those haptics moving, and then once those haptics are moving, that's when we start irrigating, because that cold fluid is going to make the lens unfold even more slowly. So we're on a viscoelastic mode here, lots of movement in the eye. Viscoelastic mode, we start the vacuum at a higher setting, and then before we go behind the IOL, I switch back to cortical removal mode, which has a lower initial vacuum. This looks good. We're going to use BSS to hydrate the wounds. We first of all hydrate the main incision. Here we're just hydrating the wound. We're not really injecting BSS into the anterior chamber. Some of it does go in, but we use the paracentesis to actually fill the anterior chamber. We see there's a little piece of material there, lens material. I'm going to go back in there with the IA to get that out. Once again, if I'm going to go back in through the main wound, I'm going to hydrate that wound again, hydrate the anterior lip, get a nice watertight closure, fill the anterior chamber with BSS, push the IOL back, make sure the optic is behind the anterior capsular leaflets, check the IOP. We're happy with that. We're going to check the wounds with Wexel sponges, and that's a wrap. Questions, comments about small pupil cataract cases, please drop them in the comments below. We're going to be showing a series of small pupil cases throughout the following weeks. Thank you for your attention. Have a great day. Hi, Mohammed Al-Mala here. Welcome to case 3 of our small pupil cataract surgery series. I found this case also from 2016, and as you can see here, the pupil is quite small. It looks like there are some posterior synechiae here where the iris is attached and scarred down to the underlying lens or the anterior lens capsule. We are putting viscoelastic into the anterior chamber, dispersive viscoelastic here, and we see that with viscodilation, viscomydriasis, we get maybe a 3 millimeter pupil. So my first step here is going to be to lyse these adhesions. I'll probably use a cyclodialysis spatula to separate the iris from the lens, and then we'll assess the pupil, see how much dilation we get, and then go from there. We'll make a plan as to whether to use a pupillary expansion device or to proceed without it. This is a cyclodialysis spatula right here, and you can see it's fairly straightforward to lyse these adhesions. But you can see the posterior synechiae here really are quite extensive. They're not just at the pupillary margin, but they go a little bit further back as well. So we'll do as much as we can here through the main incision, but we may have to go through the side port incision to release some of these adhesions here that are sub-incisional. We'll see. So no, it looks like we were able to do that through the main incision. But if you're not able to, you can always go in through the paracentesis, and of course you can always make another paracentesis to allow you for better access. So we're going in here with viscoelastic, see how much dilation we get. We have a nice, the pupil is more round now, but still only about 3 millimeters in size. So probably this is not going to be a case where we can just do viscomydriasis. We're probably going to end up needing to do some sort of pupillary expansion device, and my go-to, of course, is the Malyugin ring. I'm putting together a case series on small pupil cataract surgery. I'll attach a link to the playlist in this video. I'll see if I can put it in the comments as well. And we're going to put together a series of small pupil cataract surgeries. So here I'm using a Malyugin ring. I use 0.12 forceps to open the main incision and hold it open. And then it's really nice here if you're able to, as you inject, to engage as many of the coils as possible. Not always possible, but sometimes we're able to engage some of them. Here we have engaged 2 of the coils on the pupillary margin, and now we are removing the inserter. This is a full unedited case, and we're seeing this in real time. So sometimes putting in a second instrument can help release the Malyugin ring from the inserter. So we will place each of these coils one at a time, and the Malyugin ring provides 8 points of fixation for each of the coils and for midway between each of the coils as well, and does give you a nice round pupil. I have a whole other video on how to place a Malyugin ring, and I'll try to link it to that as well. So one way here, when you're first placing the coils, is to place viscoelastic between the iris and the lens, and that can create that potential space for the coils to go into. So we've placed here the third coil, and we're having a hard time getting that luster out of there. MST has a nice instrument to help place these Malyugin rings, and it could be a nice second instrument. I'm not using it here. So more dispersive viscoelastic. Want to make sure the corneal endothelium is nice and coated as we're doing this. And we're just checking that coil there, and then we'll place the third coil now. Okay. The fourth coil rather. So now the final coil is placed. We see a nice big round pupil here, and we can proceed with surgery. We see where the iris, the posterior synechiae is still attached to the anterior capsular surface there. We put in more more dispersive viscoelastic. We want to make sure we have a nice stable anterior chamber, and then we'll go in with the cystotome followed by the capsulorrhexis forceps. 0.12, very important. Stabilize the globe. Make sure things are nice and stable for you and secure. and you can take your time and feel confident doing the procedure without having to worry about the patient moving. So we've initiated the capsulorrhexis here. We'll make a few more passes there to raise the flap. And then we're going to go in with capsulorrhexis forceps and make a continuous curvilinear capsulorrhexis. Okay, very good. We're getting some good centration here. Things are proceeding nicely. So having a Malugin ring doesn't make you immune from having iris prolapse. So we've still got to be careful about avoiding iris prolapse as we do the hydrodissection. So go in, we raise the capsule, a little bit of air bubble there, and we raise the capsule and we hydrodissect. Thankfully, no iris prolapse here. At this stage in my career, I was doing some hydrodelineation, and it looks like I'm doing that here. And this is with the Bausch & Lomb Stellaris machine, which is a Venturi system. I am doing still horizontal chop. With this machine, I would go in and create a central core here, carve out a central core, and then I'd go in with an Aguilar chopper and do a horizontal chop maneuver. So we bury the tip into the nucleus here to get good counter traction. And that looks actually like a pretty good crack. The resolution in this video is really quite low, but I can tell we've got a good crack there. Decent rotation. Looks like I'm going to do a second crack here and try and get at least 1/4 out. So we've got one heminucleus has been split into quarters. We've got our first piece out here. You can see with the Venturi system how that piece really just comes up quite readily. Decent rotation. And now we've got the second heminucleus. We'll crack again, a horizontal chop, and we'll remove that piece here. Venturi system quite efficient in emulsifying those pieces. Okay, I'm going to crack some more, do some more horizontal chops. And surgery is proceeding well. We're making progress here. And we're probably going to have an epinuclear shell because of the hydrodelineation. So the epinuclear shell is really nice when you're learning phaco chop. It gives you a little bit of buffer between you and the posterior capsule. I don't do hydrodelineation anymore, but I think when you're learning phaco chop, it is nice to have that. Then, of course, you got to deal with removing the epinuclear shell at the end of the case. So here we have the epinuclear shell, and with the Venturi system, it's really quite easy. You've got high vacuum here. I have my second instrument protecting the posterior capsule. But yes, here we remove the epinuclear shell. There is still some cortical material, and we're going to get that, it looks like, with IA. So I'm happy with that. We've gotten the nucleus out. While I'm waiting for my scrub tech to get the IA, I will go ahead and inject some BSS through the side port just to remove any lens material that may be there. And then I'm going in here with IA, and we are removing the rest of the cortical material that's there. Some subincisional cortex still remaining. And then we're going to polish the posterior capsule here, most likely with the terry squeegee, and then put in viscoelastic. Oh, it looks like I'm not polishing the posterior capsule. We're just going to fill the capsule bag with viscoelastic. We're using a cohesive viscoelastic. We'll insert the intraocular lens, And I'm using a Softech hydrophilic acrylic lens here. I don't use this lens anymore, but at the time this is the lens that I used. And it actually worked out really quite well for many of my patients. And then before we go in with IA here, we got to remove the Malyugin ring. Very important. If you go in and remove the viscoelastic like you're in autopilot, you're going to have to go back in and put viscoelastic in to remove the Malyugin ring. So I like to remove the subincisional scroll first, and got to make sure that scroll stays above the iris. If it goes behind the iris, it's not a big deal. You just got to spend a little more time getting it out and possibly using a second instrument. So two of the scrolls are off, and I remove that third scroll off the iris, and I'm curious to see how I'm going to get this out of the anterior chamber. It looks like I may be just using Westcott scissors to cut it, which is my preferred method, but of course you can reload it onto the inserter as well and just pull it back in. Sometimes if you reload it onto the inserter, it can torque in ways that you don't predict, but I like to just go ahead and cut it with Westcott scissors. I don't reuse these, they're not reusable, and then I pull it out of the anterior chamber with 0.12 forceps. So the Malyugin ring is fairly atraumatic in this case, and we're going to go ahead and now with IA and remove the viscoelastic. We'll go behind the lens. We'll remove all the viscoelastic from the anterior chamber. We'll hydrate the wounds, and that will be it for the case. So, small pupil cataract surgery, case number 3 of the series. Make sure to check out all the cases. I'll link to the playlist. If you have any questions or comments or things you think I could, that we should do differently, or you want to share your technique, please feel free to comment. Thanks for checking it out. I'll see you in the next one. Hi, Mohammed Al-Mala here with case 4 of our small pupil cataract case series. So let's start this case here. We'll get started. This is a case actually from last year, 2024. And we can see that we have a moderately sized pupil between 4 and 5 millimeters here in size. We are injecting preservative-free lidocaine followed by preservative-free epinephrine. And the epinephrine really doesn't dilate the pupil very much. It just helps to keep it from coming down, helps to prevent the pupil from coming down. And then shortly here, we're going to inject viscoat into the anterior chamber. We'll get some viscomydriasis or viscodilation. So this is case 4 of a series I'm putting together for how to manage small pupils. I'm going to put a link for the playlist, which features all these cases. I also have some other videos on managing small pupils. I think it's important before attempting to manage small pupil cases without using a pupillary expansion device to be comfortable using pupillary expansion devices, and especially iris hooks. So if at any point in time you feel like you're in trouble or you're having a difficult time with visualization, you're able to put the hooks in and rescue your case. So here we're doing the capsulorrhexis. I have 0.12 forceps stabilizing the globe. I use the 0.12 forceps with the paracentesis. Whatever method you use to stabilize the globe, I think it is nice rather than just relying on the patient being still. It gives you a lot of confidence when you do your case to know that the globe is stabilized. And here we're doing the capsulorrhexis. You see, we're not afraid to go right up to the edge of the pupil, and we can follow the pupillary edge here, or if the pupil is smaller, we can actually go underneath the pupillary margin to complete the continuous curvilinear capsulorrhexis. Okay, that's done. Next step, of course, is hydrodissection. whenever, very important when the pupil is small, to watch out for iris prolapse. So we want to be pushing on the posterior lip of the wound to make sure that the anterior chamber decompresses and the iris is not prolapsed. Not too much of an issue with iris prolapse here. And then once we've achieved hydrodissection, I just do one fluid wave. I try and achieve a cortical cleaving hydrodissection. We go in with phacoemulsification. Here is the phaco probe and the Nagahara chopper. I go ahead and start out in quadrant removal mode. I'm doing a phaco chop technique, so I go ahead and just bury my tip into the nucleus and phaco, and then we use our second hand here to do a horizontal chop maneuver and bring that instrument to the phaco handpiece tip. You can see just with that one single fluid wave, we got a good rotation here. The lens rotated by itself as I was doing the chop. We've chopped the first heminucleus using the same maneuver. And here you can go ahead and start taking pieces if you like, or you can rotate and remove and chop the second heminucleus as well, and then start removing. So it looks like in this case, for whatever reason, I decided to go ahead and remove the first quadrant. And we're using the Alcon Centurion here. We are using intelligent phaco, so most of this is torsional, and then it kicks in longitudinal phaco as well. So I've gone now in the last few months to relying more on longitudinal phaco with this machine, but whatever settings you like and you feel are most efficient for you, and it's number one, safest in your hands, and number two, most efficient are the settings that you should use. So we've removed two of the quarters here. We removed half the nucleus. We still have half the nucleus left, and it is not chopped. It's still intact. Good rotation here with just that one continuous fluid wave that we got with the hydrodissection. And looks like I'm going to chop here. So we chop that second heminucleus, kind of a vertical chop there, but that's fine. I think with denser nuclei, it's easier to do a vertical chop, even though this is not a sharp tipped chopper. You're still able to do some vertical chop with this chopper. And then we go ahead and remove the third quarter. You can see that we're making good progress here. Even though the pupil is small, we're able to work in the center of the pupil and really have good visualization of what we're doing. If you're doing phaco chop or horizontal chop, you really don't need that great of a visualization. It actually lends itself nicely to doing small pupil cases. I think it's more difficult to do small pupil cases without a pupillary expansion device if you are doing divide and conquer. So we can see we still got some cortical material here, and our hydrodissection did not achieve complete cortical cleaving, so we still have a layer of cortex here that we need to remove. It is harder sometimes to achieve cortical cleaving hydrodissection when the pupil is small because you can't actually visualize yourself tenting up the anterior capsule. You can't visualize that triangle sign. So we're going in with IA, and we are removing the cortical material. Really nothing special here. You want to be careful about not snagging the iris. You want to make sure you're below the capsular rim or away from the iris margin. It's not uncommon or unusual to snag the iris here with your IA probe. If that happens, you just stop irrigating, reflux, and release the iris. But nonetheless, it's better if you're able to avoid doing that because it will make the pupil come down even more. So we've removed the cortex here. We still have some remnants. I'll probably use a terry squeegee here to capsule polish. And you can see I zoom in so I can get a better view of those little remnants there that are on the posterior capsular surface. And I use a terry squeegee which is a cannula with a silicone sleeve to polish that posterior capsule and just to remove any of those little material there that are on the posterior capsule. So once we do that, we're going to inject ProVisc, cohesive viscoelastic, into the capsular bag. We zoom out again for that part of the procedure. And we fill the capsular bag and the anterior chamber with viscoelastic, and then comes our lens. Also be careful here not to get iris prolapse whenever you inject your viscoelastic. Sometimes you can get iris prolapse during this part of the procedure. we deliver a single-piece hydrophobic acrylic IOL into the capsular bag, and then I go ahead and position that with the IA handpiece directly. I do not initiate irrigation until the haptics start to unfold, because the irrigation fluid is cold and it's going to make it take longer for the haptics to unfold. So once the haptics start unfolding, then I go ahead and turn on irrigation and I irrigate and aspirate out that viscoelastic material. So if the optic is about 6 millimeters in size, we can see our pupil here is probably about 4.5 millimeters. This is a Charvel, or a second instrument that I use to retract the iris to make sure we're not leaving any cortical fragments or cortical remnants or cortex behind. And that looks pretty good. And then we are done with this case. We'll just go ahead and hydrate the wounds. We'll hydrate the main incision first. I'll hydrate the roof of the main incision first. And we're not really reforming the anterior chamber when we're at the main incision. At the paracentesis is where I reform the anterior chamber. And we're going to the right and left of the wound here. We are looking, just making sure we're not leaving any nuclear fragments behind. Since we've gone into the main wound again, we're probably going to have to irrigate that main wound again, or maybe not. We may have already achieved a watertight closure. So I always check with Wexel sponges. I always check my incisions, make sure they're nice and watertight. And looks like we got some leakage there at the paracentesis, and I'll continue to work to make sure that we have a watertight closure. So that's handling a small pupil without a pupillary expansion device. It's not the smallest pupil, but using that phaco chop technique, you really are able to do that without requiring a pupil expansion device. Questions, comments, please leave them below, and look for the next case in this series. Thank you for your attention. All right. Okay. I apologize in advance for the poor quality of this video. This case is from 2020, and not all my ORs are equipped with the best cameras at that point in time. But nonetheless, I thought there was some teaching value and some learning value from this case. Hi, Mohammed Al-Mala here. We are doing a case series on small pupil cataract surgery. This is case number 5 of the series. Make sure you check out the whole series in the playlist, which I'll link to in this video. This patient obviously has pseudoexfoliation. How do we know that? Well, you see the material in the anterior lens capsule. You see 2 rings there. You see 1 ring close to the iris margin, and you see an inner ring of pseudoexfoliation material. The material is deposited on the anterior lens capsule, and you can see an area where there is no lens material deposited. There is no pseudoexfoliation material deposited, because that is where the iris moves back and forth. So what do we need to look out for when we're doing cataract surgery in a patient with pseudoexfoliation? Number 1, pseudoexfoliation patients may not dilate well, as we can see here. Number 2, the pseudoexfoliation material can make the zonules lax, and that can make cataract surgery more difficult for multiple reasons. It can make it more difficult to do the capsulorrhexis. It can make the posterior capsule more floppy and make it more likely that you capture the posterior capsule in your phaco probe and get a posterior capsular rent. And number 3, because of that zonular laxity, it can make the IOL outcome, or the final IOL position, or the effective lens position, less predictable. So these patients can have a higher risk of a refractive surprise. So you can see here, this pupil is probably about 4 millimeters. We're able to complete the capsulorrhexis. We're going to go in here and do hydrodissection. We've got to be careful here that we don't get iris prolapse. So we tent up on the anterior capsule, but there it is. We get some iris prolapse. As soon as it starts prolapsing, we stop injecting. We push on that posterior lip of the wound. We decompress the anterior chamber, and that allows the iris to fall back in. Do not push the iris back in without decompressing the anterior chamber first. The iris is a very soft tissue. It's going to follow whatever pressure gradient you give it. So if you increase the pressure inside the anterior chamber, and it's more than the pressure outside the anterior chamber, the iris will prolapse. And if you try to push it back in, it will not work. You have to decompress the anterior chamber first. So we are doing a horizontal chop technique here. This is with the Bausch & Lomb Stellaris machine, a Venturi system. We have chopped and isolated one quadrant, and we've been able to remove that quadrant. We got a good rotation here. And if you're doing a small pupil case like this and really don't have much visualization, it's important. Two things are very important. Number one, that you get a good crack. Number two, that you have good rotation. If you don't have either of those, this case can be significantly more difficult to do, and at which point in time you can go ahead and put in iris hooks or do whatever you need to do to get better visualization of this lens. So far, we've got two good things here. We've got a good crack, and we have good rotation, so we're able to break up this nucleus into smaller pieces and pull those out with our very efficient Venturi system here. So as you can see, we're working within that small pupil. I already have my second instrument behind the nuclear material. We want to keep that posterior capsule back, especially in this patient who has pseudoexfoliation. So we're making good progress here. And I think that's all the nucleus there. And so we just have a little bit of cortical material remaining, and we're going to go in with the IA probe and remove that cortical material. So while I'm waiting for my tech here, I'll go ahead and put some BSS through the paracentesis. That helps me maintain the anterior chamber, number one. Number two, it also helps to remove any kind of lens material that may be hanging out in that paracentesis, so we can remove it as we do IA here. Irrigation aspiration, we'll go in and we'll aspirate out that remaining cortical material. In a patient with a small pupil, it's easy to grab the iris when you're doing this. And so we want to be careful not to grab iris as we remove this cortical material. So check out the playlist for all these small pupil cases. I'd love to see how you do your small pupil cases. This is a Charvel, an instrument to retract the iris. I'm looking for any remaining cortical material. I now do this part usually after I've already put the IOL in. I like to have the IOL in and have that scaffold in place to protect the posterior capsule from my IA probe. Looks like I'm doing some capsule polish here with the back of this IA handpiece. I also sometimes use the Terry squeegee to do capsule polishing. But we're making good progress here. So I'm probably going to inject Provisc now, cohesive viscoelastic. Oh no, we're going to do Terry squeegee. We're going to polish that posterior capsule some more. And this is just a cannula with a silicone sleeve that you can use to irrigate as well as polish the posterior capsule. You can mechanically polish with the tip of the silicone probe. You can also polish with by irrigating. So two mechanisms by which that Terry squeegee can polish the posterior capsule. We're injecting Provisc here to fill the capsular bag in the anterior chamber. Watch out for iris prolapse here as well. We're going to inject our IOL, probably a single piece hydrophobic acrylic IOL here. Let's see. Yes, that looks like a Technis IOL. And here I am using a Lester to make sure that the IOL is inside the capsular bag. We want to make sure that those haptics are starting to unfold. And then we'll go in with IA and remove that viscoelastic from the anterior chamber. I like to go behind the IOL, not to leave any pockets of viscoelastic present. And that's really about it for this small pupil case. That case went really well. Remember, for these small pupil cases, especially in patients with pseudoexfoliation, you got to be able to get a good crack, number one, and you got to have good rotation. That makes all the difference in being able to do these cases without having to use a pupillary expansion device. Also, the phaco chop or horizontal chop makes it easier to do, makes small pupil cases easier to do because you don't need to require visualization of the periphery like you do when you're making a groove for divide and conquer. This is the corner one, which I'm also using to do the same thing, retract the iris, looking for any remaining cortex that may be there. So now we'll hydrate the wounds. We'll hydrate the main wound first. It looks like we're still looking for some more cortical material there. There must be something there that I saw that I'm looking for. So let's see here. Nothing really too much on this video. Sometimes, obviously with this, especially with this video, we're not seeing all the details that I can see intraoperatively. Oh, there we caught up some iris there with our IA probe. Not a big deal. We let go immediately. Don't keep pulling on the iris, and it does make the pupil come down further when you do that. So looks like we are done. We're going to hydrate the wound. We're going to irrigate the anterior lip of that main wound first, and then we're going to fill the anterior chamber through the paracentesis. And we'll check the pressure here with the 30 gauge cannula, blot on the cornea. Make sure we're happy with the pressure. And then we'll check the wounds with wet cell sponges. I always check the wounds with wet cell sponges. I always want to make sure that it's nice and watertight. Don't want to have to be guessing whether it's watertight or not. And that's it for the case. Thank you for checking it out. I hope you learned something from this. Leave any questions or comments in the comment section below. Thank you very much for your attention. Hi, Muhammad Al-Mali here with another case of a small pupil cataract surgery. This is case 6 of our small pupil cataract surgery series, and this patient is having a toric IOL placed along with their cataract surgery. The stereostrip you see down here at the bottom right of the screen is placed because during the draping, my tech didn't get all the lashes, so rather than trying to re-drape the patient, I put a stereostrip there to cover those lashes and prevent them from getting into my field and contaminating my instruments. So this pupil is a little bit over 4 millimeters. You can see there's a lot of debris in the tear film, making the visualization more difficult. With the extra stereostrip there, when we hydrate or irrigate, the fluid can get backed up. And nonetheless, we have a decent view here. We've already injected viscoat into the anterior chamber. We've achieved some viscomydriasis here already. The pupil looks already about 5 millimeters here, which is plenty to do a capsulorrhexis. 0.12 forceps to stabilize the globe. We're trying to irrigate all that stuff off before we do the capsulorrhexis. It's best to irrigate right at the limbus, temporal limbus there, and that helps to draw all that material off of the cornea rather than trying to irrigate right over the center of the cornea. You can see my tech did that. It really pulls a lot of that material off the ocular surface. So continuous curvilinear capsulorrhexis here. We've already used a cystotome. I use my capsulorrhexis forceps, cross-section forceps here. We're not afraid to go right to the pupillary margin. Regrasp as needed. Every time before I regrasp, I bring that capsule back so it's easy to regrasp. So before I let go, I'll bring it back again so I can regrasp. Well, it looks like I'm not going to regrasp it. I'm just going to finish the capsulorrhexis. If you go back and watch that or watch my other videos, every time I regrasp, I want to bring the capsulorrhexis back and make it easy for myself to regrasp that rhexis. So we're going to try and achieve a cortical cleaving height dissection. We're going to tent up here on the capsule. Small pupil cases, watch out for iris prolapse. As soon as you see it happening, stop irrigating and depress in the posterior lip of the wound to decompress the anterior chamber. So here it looks like I'm having a hard time getting a fluid wave, and so I may end up just not worrying about doing cortical cleaving hydrodissection, and sometimes I'll even just hydrodelineate and do our best. So once that viscoelastic is out of the anterior chamber here, you can see that pupils come down a little bit now, maybe 4.5 millimeters at this point in time. Still plenty of space to be able to do this case. We'll go in with the phaco probe. This is a case from this year, I believe. So we have the Alcon Centurion machine, and we're going to do our horizontal chop maneuver with the Nagahara chopper. I'm going to take that phaco probe, impale the center of the nucleus. We'll reach out beyond the capsular edge there, and we'll do a chop maneuver. We've got a nice crack and a decent rotation so far. Okay, we're doing two hands here to do the rotation. We've got a decent rotation. Two things you got to have in these small pupil cases. You got to have a good crack and you got to have good rotation. Otherwise, the case can be significantly more difficult. And you add that, it can make it more difficult in any case, but especially when you have a small pupil and you have a poor crack or a poor rotation, it can just really make all the strikes really pile up against you. So we've already chopped one heminucleus. We're going to chop the second heminucleus, and then we should be starting to remove these pieces here pretty soon. I use my quadrant removal mode throughout this part of the procedure. I find that that helps to impale the nucleus. This is a large lens. You can see here I'm pulling out that quadrant. It's a large lens. It looks fairly dense. And so, it can be a struggle to do these cases in a patient who has a small pupil. But nonetheless, looks like we're making good progress. So whatever settings I'm using here, I'm not entirely certain what my settings were at this point. They seem to be working well. So I use my second instrument a lot when I'm operating. I use the second instrument to move that piece, to separate it mechanically from the other pieces so it can tumble. And we are getting good phacoemulsification here, and it's really doing a good job. This machine is really doing a good job eating up these pieces. So we've got 2/4 remaining. We'll mechanically split them again so we can get them to tumble. And that's especially important, especially when the pupil is small. Large nucleus here, especially with that small pupil. But we are making good progress here. I already have my second instrument behind my lens material that I'm trying to chew up here. I'm using that second instrument to protect the posterior capsule, especially since I really can't see it. And I really don't have too much behind this phaco probe at this point in time other than this lens material. And then we have one more quadrant remaining. Looks like we do have some cortical material there, so we will probably be doing irrigation and aspiration here. So last quadrant, really nice, making good progress here. Second instrument protecting the posterior capsule. We will go in now with IA to remove that cortical material. While I'm waiting, I'll inject some BSS through the paracentesis, keeps the anterior chamber formed, removes any of that nuclear material that may be bunched up in that paracentesis. I hate when I'm irrigating at the end, all that stuff just comes out. I have to go back in there with the IA handpiece to remove it. So I go ahead and irrigate out while I'm waiting for the handpiece. Really, it gives me something to do while my scrub tech is getting things ready for me. So not really much of a cortical cleaving hydrodissection here. You can see that cortical material is really stuck to the capsule. We're going to have to peel it off here piecemeal all the way around, and that's okay. We didn't get that great of a fluid wave, and it shows here, but that's okay. We're going to do IA, and we're going to remove this cortex, and this patient's going to do fantastic. All right, so some cortical material still there remaining, not too much. I'll probably go in with my Terry Squeegee capsule polisher. Optional to do that, but I like to see that posterior capsule nice and clear. So I do it for almost all my cases. It's Terry Squeegee. It's a cannula with a silicone tip. It polishes the posterior capsule through two mechanisms. Number one, irrigating it and just using that fluid to wash off any material, and also mechanically, you can mechanically use a silicone tip to push and remove any any cortical material. So ProVisc here, cohesive viscoelastic. You see what I did there? I went to the left of the wound and the right of the wound, and what I'm trying to do there is remove any pieces that may be lodged in the anterior chamber angle, so we're not left with any surprises. We are doing a toric lens, so I'm going to use the intraoperative aberrometer, and I'm going to use that to help align my toric axis. Many different ways to do this. You can mark the patient in pre-op, many different machines to be able to do this. I use the Aura machine. We've had it for over a decade, and we use the reticle on there to align the axis and measure how much residual astigmatism we have on the fly in real time. So the patient's fixated there. We took the measurement. I've already decided what IOL I want to use, and I'm just using the toric for alignment of the axis. So once I've made the capture, I'll go ahead and insert the IOL, and then I'll go in with my IA to position the IOL and rotate it into the proper axis. A little bit of a delay here. Not sure what I'm waiting for. So I may be asking my tech for something or needing something, or she may not have the IA handpiece ready. In any case, here is the IA handpiece. When we use that to push the IOL into position, the advantage of that delay is now that the haptics are unfolded, we see the toric markings there, and we see the Aura reticle is telling us where to place the toric IOL. Once I get it roughly in position, not exactly in position, maybe a little bit counterclockwise to where my final position is. I'll go ahead and remove that viscoelastic material with IA. Remove any remaining cortical or lens material that may be in the anterior chamber, also with IA. I like to go behind the lens. Don't have to do that, but I do like to do it just to make sure that there's no remaining viscoelastic trapped between the IOL and the posterior capsule. So once we are happy with that, then we'll go ahead and look at my toric markings again, look at the reticle. I have my tech turning the reticle on and off for me as I see fit, and it looks like I'm happy with that placement. And then I'm going to pressurize the anterior chamber, and I'll take a look at probably the aura screen to make sure that things are nice and oriented with minimal astigmatism remaining, and the aura is not telling me to rotate right or left. So once I get the eye pressurized to where I wanted it to be, then I'll look at my toric axis to see and make sure that I'm happy with how much residual still there is. So actually with the reticle there, you can see it does give you, the top number there is how much, the amplitude of the still as well as how the axis of the still that's remaining. So we can see we're right around 0.4, 0.3, 0.2 still in the anterior chamber, in the whole eye system. So we've gotten our residual astigmatism less than half a diopter, maybe even 0.3 diopters of residual still. So I'm happy with that. I like that. I'm going to check the wounds, make sure they're watertight. It looks like I'm happy with that, and then I'm going to go ahead and remove the lid speculum, and that is the case. So continue with our small pupil cataract surgery series. If you have any questions or comments, please leave them below. And then we'll try and put together a video just summarizing what we've learned from this series. Thank you for your attention. I hope you learned something here. Thank you.